Hello, everyone, and welcome to Rare à l'écoute, the podcast channel dedicated to rare disease. Today, we continue to explore Cushing syndrome, and to talk about it, we are pleased to welcome Professor Nienke Biermaz. Professor Biermaz, good morning.
Good morning.
Professor Biermaz, you are Professor of Medicine at the University of Leiden in Netherlands, and you are also an internist and endocrinologist at the Leiden University Medical Center. You have a specific interest in endocrinology as you are highly involved in the care of endocrine tumors and in particular pituitary conditions. Professor Biermaz, today we'd like to address relationships between patient and physician in the Cushing syndrome. And regarding your approach of taking care of patients with this condition, apart from biochemical data, how important are patient values or patient-related outcomes?
Well, thank you very much for your question. I'm very happy to share my thoughts on this. And my thoughts are based on the care for pituitary patients, so patients with pituitary adenomas that we see in our perioperative pathway for pituitary diseases, so mainly pituitary derived Cushing and not adrenal Cushing. Well, to my view, patient-related outcomes are very important. And when we are looking at outcome data around surgery, we start, of course, with remission data and whether you're hydrocortisone dependent. But for patients, what really matters is how they feel and what is their quality of life and what are their symptoms and do they get back to work and how is their home situation and what is their burden, what is their needs. And we are increasingly interested to really have those data in the outpatient clinic to evaluate our standards of care. With these data, patient reported outcome data, in combination with the hardcore clinical data with remission and complications, etc.
And in your daily practice, how does the healthcare team integrate patient needs and expectation?
Yeah, I think that's a difficult question because when we're dealing with biochemistry, you need to be sure that it's measured in the right lab with the right standard, with the right assays, with the right reference data. And we are not yet sure what is normal values for needs and expectations. So that's still a developing world, and it's good to realize that we don't have normative data for quality of life scores, etc. What we do is that at entry, at baseline, and at 6 weeks postoperatively and 6 months postoperatively, patients are filling questionnaires on bother, on needs, on quality of life, on expectations for their disease. And we are evaluating these together with the nurse in the outpatient clinic. We're looking at the need of the patients together with the patients, and we try to address their needs for support, for example, physiotherapy, psychological care, specific medical evaluation, nursing care. So we try to address based on the patient-reported outcome measures that the patient feels around the clinical care process. But it's still difficult because you need such data. You need to have them in the outpatient clinic, and not every electronic hospital record is able to show you the data. So that's very important that is needed. That's created to be able to do something with those measures. And in addition to the evaluation together with the individual patients, we also following the outcomes of our care path by evaluating the patient-reported outcome data every 6 to 12 months. So we have an idea about the progress within our care path.
And what are the most important outcomes you think to be discussed with patients regarding the disease or their care?
With respect to this question, I think it's interesting to stick to one of the ideas that are out there in the world. For example, the 3-tier model developed for value-based healthcare. So there are 3 tiers, and the first is, of course, things as remission and mortality. Then there is a second tier that is important to evaluate the disability due to an intervention, so the recovery time, etc., etc. And there's a third tier that's designed to look at the long-term outcome. And it's important to have a holistic view of all those principles, and to look at the patient group you're caring for example, the Cushing syndrome, and look at the items and the topics that are interesting for the patients. So we decided to have first, of course, a look at remission and persistent disease, to have some idea on tumor volume, to have an idea on complications during treatment, and for example, pituitary function loss. And then we are interested in the time needed to get back to work. We are interested in the bother and needs of a patient, the general quality of life, and the disease-specific quality of life. And in the end, we are also interested in treatment related symptoms, like nasal symptoms following endoscopic surgery. For example, the visual symptoms when you have a bigger tumor, which is exceptional in Cushing syndrome, but it's important to realize that there are more patients that are cared for. So that's it. And if we're considering well-being and quality of life, it's always also important to realize that it's based on many components. So it's the disease, it's the makeup of the patients, it's the character, it is the social structure. So having a partner or not, being young, being old, having a specific coping strategy. So all those items need to be addressed when you want to interpret the quality of life scores.
And last but not least, Professor Birmaz, how do you manage to empower patients in clinical practice?
Yeah, we have been thinking about that. We first established that there is really a impaired quality of life in patients following treatment for pituitary conditions. And then in addition to medical care, addressing medical needs, we wanted to empower patients by providing them some strategies for self-management. And that's what the point that we developed together with a psychologist and a physician who is caring for general conditions. So it is targeted for pituitary patients, but it was developed for another condition. And then we made a session of 8 sessions of 1.5 hours every week, 8 times, and then we are covering important topics, helping with self-management. For example, stress reduction, for example, fatigue management. It's also together with peer patients, so they can exchange a lot of thoughts and anxieties and worries and solutions and their experiences together. And it's supported by one of the caregivers of our hospital, so it's moderated to don't have like a very negative approach, but a positive healing approach, aiming at advancing with encountering your disease, your condition in real world.
Well, thank you very much, Professor Birmaz, for all this clear information about Cushing syndrome. As for us, dear listeners, we thank you for your time, and we look forward to seeing you on our podcast channel for a future episode on Cushing syndromes. See you soon.